Shock doesn't necessarily equal hypotension, right? It's any evidence of impaired end organ perfusion. So any of these things can be manifestations of shock. Elevated lactate's a big one that the ER likes to see, but obviously elevated lactate does not equal shock. You have to look at the whole picture. This is a paper that came out last year in the New England Journal by these two guys from Brussels, Vincent and De Backer. And so it's actually a really good review article on just kind of the management of shock and how you break down shock. This is a graphic from the paper talking about the 4 different types of shock and the mechanisms behind it. Obviously, distributive shock, of which sepsis is a part of, you have a decrease in your SVR, and that's one of the main reasons. Inappropriate vasodilation in the setting of low blood pressure. Hypovolemic, obviously lack of blood volume, and so decreased preload to the heart, causing that hypotension and decreased organ perfusion. Cardiogenic shock, obviously LV failure or other RV failure, or RV or LV failure. And then obstructive shock, something we don't see as much of here, but can be due to basically poor filling or obstruction to forward flow. So obstruction such as aortic dissection, hypertensive emergency, giant PE, and then tamponade is another cause of obstructive shock. And this is another graphic, and it's actually, I like how it breaks it down. It basically says, look at the patient, okay, they've got hypotensive. Are they awake, reading the paper, talking, you have a full conversation? All right, they don't have signs of tissue hyperperfusion then, right? That's just maybe chronic hypotension from liver failure, something like that. If they have any of these signs of tissue hyperperfusion, then you say they have shock, and then you try to get an estimate of their cardiac output, or if they have a central line, you can look at their SVO2. And these are the 4 different types of shock, and if they have normal or high cardiac output, it's most likely distributive. And this is, again, from Europe, where they use echo on almost everybody. And so they can say, okay, well, you can look at the heart, contractility is usually preserved, this is distributive shock. However, if the chambers are really small, there's poor cardiac output, then this would be hypovolemic. Obviously, if the heart's not working, it's cardiogenic. And then in obstructive shock, again, you're going to see evidence of tamponade, or you'll see a big dilated RV if it's due to a pulmonary embolism. So, and it also tries to get you to look at get an assessment of their volume status. And here they use CVP, but again, we don't use that as much anymore. So just try to get an assessment of their volume status based on physical exam. So we'll talk about that. Another interesting little picture here is the breakdown of shock, and obviously most of it is septic shock, not so much obstructive or the non-septic causes of distributive shock. These are equations that you all should know. I like this one because obviously it helps you kind of break down why is their MAP low. Is it because they have low cardiac output, and to compensate the SVR is going to go up, like in cardiogenic shock or hypovolemic shock, or is it because SVR is low and therefore the cardiac output has to increase to kind of compensate to keep the MAP up, and that would be in your septic shock. This was always an equation that I had a hard time remembering, but it's easy if you think about it in terms of a ventilator, right? Resistance equals change in pressure over change in flow. It's the difference in your pressure from the left side of the heart to the right side of the heart over the difference of the change in flow, which is your cardiac output. And then obviously, to try to get an assessment of cardiac output, you can use a surrogate for stroke volume, which is pulse pressure, the difference between your systolic and diastolic. And because of that, we can get an assessment of their cardiac output at the bedside. And Kevin Simpson always likes to talk about this. Narrow pulse pressure, cool extremities, thready pulse, that's going to be decreased cardiac output shock, such as hypovolemic or cardiogenic. And then if they have wide pulse pressure, bounding pulses or warm extremities, that's more likely your increased cardiac output shock, which would be septic shock or distributive shock. Yeah, this is just breaking down the causes of cardiogenic shock, and again, it can be LV or RV. And when you're thinking about RV failure, you have to think about whether they have pulmonary hypertension or no pulmonary hypertension. If there's pulmonary hypertension, it's usually due to some sort of lung cause, and they're kind of throwing PE in here, but again, that's a cause of obstructive shock. And if there's no evidence of pulmonary hypertension, that's when you're going to think of your inferior MI causing an RV infarct. So lots of different causes of cardiogenic shock, something we don't see so much in our MICU, but something to think about. Hypovolemic shock, I just put this up here because I don't know how many of you guys have used these. You guys ever use these? I love this thing. So it's a rapid infuser. I used it 3 times when I was a fellow. It's really fun. So somebody's massively GI bleeding, right? Pouring blood out, your liver patients, whatever. You throw in a Cordis, and then you get this from either the trauma nurses or the ER, they have them. And so it can give blood at 30 to 1,300 mils per minute. And so it basically pours in blood products, right? And it has this little thing down here that takes all the bubbles out, and then it has this thing right here that heats it up. So it's 36 degrees Celsius. So the 3 patients I used it, 2 of them died, 1 of them lived. So it's actually really fun to use, but you have to call one of the SICU nurses or the ER nurses to come up and tell the NICU how to use it, because they don't know how to use it. And obviously if you put in a huge air bubble, you're done. So this is just a review of causes of obstructive shock, like we talked about. Tamponade due to decreased venous return, or their massive PE or hypertensive crisis causing increased afterload. So our high cardiac output shock is your distributive shock, inappropriate vasodilation. And these are the 3 causes other than sepsis, right? Your neurogenic, which we don't really see that much. Anaphylactic, again, we don't see that much. And adrenal crisis, not that common. And again, from that breakdown, it was only about 4% of the causes of shock that we see. Septic shock, you guys all know this. I only put this up here because it's important to realize that not everything that meets SIRS criteria and has an infection is sepsis, right? Because if you label somebody as sepsis and then they die, we get dinged. And so if somebody has really bad back pain and they're tachypneic and they're tachycardic and then they have an incidental UTI, it's not sepsis. So don't let your residents put sepsis in their note, because then we have this really high, we're like 112 out of 119 hospital academic centers that are looked at in terms of our mortality for sepsis. And so they're really looking at this and trying to figure out why our mortality is so high. And I think it's because of this. Our coders are so stuck on this that they're like, well, they meet sepsis criteria, but really you have to look at the patient as a whole. Oh, the early goal-directed therapy. So Rivers, right, 2001, everybody knows this. 260 patients randomized to standard therapy or intervention, and the standard therapy really wasn't that bad, right? Antibiotics, IV fluids, pressors, intubated if they needed. The intervention group, the only difference was that they had this continuous SVO2 monitor, right? That watched their SVO2 constantly. If it was less than 70, they got packed red blood cells to a hemoglobin of 10, and if it was still less than 70, they were started on dobutamine. That was the intervention. And that's just the breakdown as you can see it here. See, they got all the things that they were supposed to get. Although, who was that Journal Club? Sri, you were there, right? Yeah. How Loggy says that Rivers completely neglected his control group. Yeah, exactly. Tell the medical student to go take care of them. Just a review of mixed venous O2 sat, right? It's a balance between O2 delivery and O2 consumption. So normal SVO2s returning to the heart is 75%. So Sri, tell me the equation for oxygen delivery. Have you done Fahey pulmonary consults? But yes. Okay. Well, right, of course. But he gives his oxygen lecture to everybody. So what is the equation for oxygen delivery?
It's cardiac output times 1.35, or whatever the content of hemoglobin.
1.34.
1.34.
Yes.
Times the amount of hemoglobin times the saturation.
Yeah. Times some negligible number, right? Or plus some negligible number. And so 1.34 is the amount of mils per oxygen a gram of hemoglobin can carry, right? And so this is important because this explains why Rivers did what he did, right? So he said, okay, if there's a decrease in your SVO2, it's either because there's decreased oxygen delivery or increased O2 consumption, right? This almost never happens, the increased O2 consumption, only with super high fever, really bad increased work of breathing. So this really never happens. The main thing, and this is going to be a question on the boards because it was in all my practice questions and on, I think, both my boards. If the question is, how do you increase O2 delivery? It's always going to be increased cardiac output, because if you look at the equation, this has the biggest contribution. So if they give you these 3 things and, give them a blood transfusion, intubate them, or start them on dobutamine, it's always going to be start the dobutamine to get cardiac output up. So that's why he did it. He started dobutamine, he gave them a blood transfusion. And of course, he found a 15% absolute risk reduction in mortality. However, his control group, again, he put the medical student in there, and they all died, and so the mortality was 50%. And so his intervention group had really the standard sepsis mortality. And a lot of people say that he was in bed with Edwards, who made the catheter. So regardless, there were 3 studies ongoing, Australia, Great Britain, and here. This is the one from here. It came out 2 weeks ago. Sri and Ed already saw this because they were here yesterday at Journal Club. 1,300 patients in American ERs, UAB, Brigham, Pittsburgh, some other hospitals. In the ER, septic shock, randomized, big group of patients, right? And so they either got, Rivers protocol, standard protocol, or usual care. And this was the Rivers protocol. They went exactly by the Rivers protocol. They got this special catheter with continuous SVO2 monitoring. They got transfused to hematocrit of 30 and dobutamine. This group, I like this protocol because basically it says, yeah, give them a bunch of fluid, but look at the patient. If they appear volume overloaded, JVD, frothing secretions, increased O2 sat, stop the fluids, don't go crazy, and start them on pressors. And if their hemoglobin, they transfuse for hemoglobin less than 7.5. And then they started dobutamine at the discretion of the physician. And so it's actually a pretty good protocol that I really like. And they didn't need to put in a central line if they didn't want to. They said if there's 2 large bore IVs, then you can use it. That's great. So, which is interesting because these are all academic centers. And then usual care, they said doctors do whatever you want, but there was somebody watching them to make sure that they weren't completely neglecting the patients. This is just looking at, so they all got the same amount of fluids before randomization. From randomization to hour 6, you can see that the Rivers people, they got about 2.8 liters. The standard protocol, they got a little bit more, and then the usual care got less. But still a good amount of fluids. And then if you look at time 0 to 3 days, the people who got the most amount of fluids were the people who they were going and looking at the bedside and seeing if they were fluid overload, which I thought was interesting. Other thing I thought was interesting, 60% of people, even outside the Rivers protocol, got dobutamine. I don't use dobutamine on 60% of my septic patients. So, I don't know. Maybe we're doing something wrong here. But a lot of people got dobutamine, even though it wasn't written in the protocol-based standard therapy or usual care. And then this is the kind of bottom line of the study, no difference in mortality, either at 60 days or 90 days in either of the groups. So about 20% mortality, which is pretty good in sepsis. So what I thought was interesting was that despite the people who got a ton more, more fluids, remember this group, no difference in respiratory failure, which is something I'm always worried about, is putting the patient, giving them too much fluid and sending them into respiratory failure. There was a significant difference in the amount of patients who needed renal support, and this was like dialysis. So the people who got the most amount of fluids went into renal failure. A little weird. So, but no other differences in any other outcome. So it was. So this is kind of what they said, is that despite having this really rigid protocol by Rivers, another pretty rigid protocol that was come up by the experts, the standard protocol, no difference in mortality and morbidity, and they said we also found no benefit to the mandated use of central lines or central hemodynamic monitoring like the CVP, which we all know is silly. So obviously a lot of things that we did learn from these early goal-directed therapy, early antibiotics, right? This is a big paper, came out in 2006. The longer, every hour you delay antibiotics, your survival decreases by about 8%. So early antibiotics, I think the residents are all really good about starting early antibiotics here. This is from that New England Journal paper last year. They say treatment of shock is VIP, so intubate them early if needed, right? They're compensating for their metabolic acidosis. BiPAP, you can try it, but look at them after about 30 minutes to 60 minutes. If they're failing, just intubate them. Infusion, obviously, we use crystalloid and then pressors. A little thing about fluid responsiveness. None of you guys were here. Were you guys here for my fluid responsiveness talk? I think I did as a first-year fellow. So everybody missed it. But so I stole a lot of these slides from that talk. So 50% of patients with shock, only 50% of patients with shock respond to fluids, right? And when they say respond, they mean a significant increase in stroke volume or cardiac output. That's how they define volume responsiveness. Too much fluid can lead to increased time on the ventilator and increased mortality. That's why I'm surprised about that paper that showed the people who got 8 liters versus 6, no difference in the incidence of respiratory failure. These are a couple of the papers showing that increased volume status, and they're using CVP as a marker, leads to increased mortality. This is a retrospective review of the VAST trial, dividing 3 groups based on their CVP at 12 hours, and what they found is that those who had a CVP of greater than 12, these people, had a lower survival rate. And obviously the people with the lowest CVP had a better survival rate. And this was actually adjusted for age and Apache 2 score. And then this was another one looking at the ARDSNet group, and you've seen this trial before, right? This was talked about for the boards and everything like that. Conservative versus liberal fluids. Those who got conservative fluids, meaning a CVP less than 4 and a wedge less than 8, shorter ICU length of stay, more ventilator-free days. So just a couple of the many papers out there showing that too much fluid is bad. And that's because we have no idea where these patients are on the Frank-Starling curve, right? Are you down here where fluids increase your cardiac output, or are you up here where a lot of fluids have almost no increase in cardiac output? Or are you in heart failure? Or do you have this septic myocardial depression, where they found that a bunch of patients who were in septic shock had, this is right, a normal curve. This is the people with septic without shock. Those who were in septic shock had this severe depression in their cardiac output, similar to like the heart failure curve, and they think it's because of this circulating myocardial depressant factor. So if you get an echo on your septic shock patient and the EF is really poor, it's maybe because of this. And if you repeat the echo in about a week, it goes back to normal. So this can happen in some patients with septic shock, even though classically septic shock is supposed to have preserved or increased cardiac output. So that New England Journal paper from last year says that I actually like how they do the fluids in the standard protocol arm. You know, give a bolus, go back, look at the patient, see if they're frothing at the mouth. This is another one where you basically give a bolus about 500 cc's and then define a positive test. And I like to tell the interns this, right? Don't just write for, you know, continuous fluids until they're intubated. Go back and look and see, did the heart rate go down? Did the MAP go up? Are they increasing urine output? Are they starting to wake up? Look at your endpoints. Don't just start giving fluids to a target CVP of 12, 15 if they're intubated. And then they'll say, set a safe limit. If you're using the CVP, which we don't like to use, stop it once it's above your baseline. So some people use CVP and maybe it's helpful for a trend. If they start at 2 and now they're 10, if they start at 18 and now they're 2, maybe that's helpful, but they love it. Love it. I know. The CVICU, the SICU, right? We have a patient up in the SICU and the nurses are freaking out that we don't have a CVP. It's just they all use it and we don't. But if you use it, stop after it's risen 4 above the baseline. Don't go for this crazy number of 15 just because that's what's in the protocol. And then don't be putting a central line in during your fluid challenge because then it's going to, you know, they're going to get tachycardic and hypertensive because you're jamming in their neck. Oh, this is my favorite slide. You've all seen this, right? The 1984, so gosh, 30 years ago, this paper came out showing that CVP has absolutely no correlation to body fluid status. None. 0. This is a meta-analysis, 15 papers, looking at the CVP in your responders, meaning you give them fluid and they have an increase in their cardiac output, and your non-responders. You give them fluid, they have no increase in their cardiac output. Average CVP in your responder was 8.7, CVP in your non-responder is 9.7 on average. So the area under the curve was 50%, so it's like flipping a coin. So tons of experts out there say don't use CVP even though it's still in our surviving sepsis protocol. They'll never let it go. Indications, there are some indications that are for monitoring of CVP, like if you are a post-op heart transplant, so in the CCU they like it, RV infarcts they'll use it, and then for massive PE we used one once at the VA for somebody who had a saddle, so the surgeons wanted a CVP for monitoring. Wedge pressure, again, something that we used to use but don't use so much anymore. This is another meta-analysis looking at wedge in responders and non-responders, and you can see this is 9 different papers, and in none of the papers was there a significant difference in the wedge, and in fact, in this paper, the responders had a higher wedge than the non-responders. So it's really difficult to look at wedge and try to get an assessment of volume status because there's so much that can affect the wedge pressure, which is supposed to be an estimate of your left ventricular and diastolic pressure, which is supposed to be an estimate of your filling pressure. So we don't use wedge pressure anymore. So then what can we use to try to get an assessment of volume status? There are all these dynamic measurements that are coming out, delta pulse pressure, stroke volume variability, and echocardiogram. This is kind of how, this is explaining how changes in your intrathoracic pressure affect changes in your cardiac output. And so when you're on a ventilator and the ventilator gives a positive breath, the patient's completely passive, so they have to be passive to get a positive inspiratory breath. If they make an effort, it's negative. So they have to be passive on the ventilator. It gives them a breath, it increases their pleural pressure, and it decreases RV afterload, right? Because of the increased pressure, the RV is pumping against that, and so you have a decrease in your RV afterload, which leads to a decrease in your RV stroke volume. The increase in pleural pressure decreases venous return to the right side of the heart, which decreases your preload, which again contributes to your decrease in stroke volume. So then by the time that decreased stroke volume from the RV gets to the left side of the heart, now the patient is exhaling because it takes a while to get through the pulmonary circulation. So during exhalation, there's a decrease in your LV stroke volume and your pulse pressure goes down, right? Pulse pressure is a surrogate for stroke volume. On the other side of the heart, during that positive inspiratory breath, it it squeezes all the capillaries, the pulmonary capillaries, and dumps blood into the left side of the heart. So you have an increase in your preload, which increases your stroke volume. And also, as we know, positive pressure decreases LV afterload. So that means during inhalation, when the patient is given a breath on the ventilator, there's an increase in their pulse pressure, and when they exhale, there's a decrease in their pulse pressure. And that change is emphasized or even greater when the patient is volume depleted. There's greater swings in the change of your pulse pressure or your stroke volume. So again, this is just showing there's an inspiratory breath and there's a bigger change in your pulse pressure, and then here's exhalation where there's a smaller change in your pulse pressure. And so this is, you can look at their either heart rate or their pulse ox. And so that's what this FlowTrack monitor looks at stroke volume variability. They've done a ton of studies looking at this. This was a meta-analysis from 2009. Great sensitivity and specificity for a cutoff of about 11 to 13. So if you have somebody who's perfect for this and their stroke volume variability is 16%, meaning there's a huge amount of variability from inhalation to exhalation, then they are volume depleted and they will respond to fluids with a very good sensitivity and specificity. You can also use echo, and what we would use here would be the TTE to look at the IVC, and what it's supposed to do is during a positive pressure breath, it's supposed to dilate, and then as the patient exhales, it collapses. And so this is somebody who has no response to fluid, right? There's no change in the IVC between exhalation and inhalation. However, here you can see it's supposed to be 95% change. I don't know where they get this number, but you can see a change, right? And then they give them fluid and that change is less. And so they say that if you have a change in your IVC of greater than 18%, that's very specific and sensitive for volume responsiveness. So, but they have to meet all these criteria, right? They have to be a normal sinus rhythm. They have to have huge tidal volumes because you've got to get those changes in positive pressure, in intrathoracic pressure. Their PEEP can't be more than 5. They can't be breathing on their own, and they have to have normal chest compliance. So no fat people, no open chest, nothing. So nobody meets these criteria ever. So that's why we don't use it. It's too bad. But if you ever wanted to use it, you have to paralyze them, make sure they're in normal sinus rhythm, and then jack up their tidal volume to over 8 cc's. And that's what they do whenever they do these studies. They paralyze them and then transiently increase their tidal volume if you want to use this. The ER loves this, right? IVC variation in non-mechanically ventilated patients. So this was a paper that came out in our literature a couple of years ago saying that we should use it cautiously because if they have a huge amount of variation, so over 40%, then there's a pretty good chance that they are volume responders. But look, if they're less than 40%, it means they're a non-responder, but also there's people who could respond who are less than 40%. So that's why they say that you should use this cautiously. If they have a huge amount of variability, sure, they're probably not going to be non-responders, so you could probably give them some fluid. But if they're less than 40%, then it still could mean that they would respond to fluid. So they came up with an area under the curve of 0.77. So not the best test, even though the ER loves it. I don't really trust it yet. But I'm going to an ultrasound course in May at the ACCP. I'll let you know what they say. You guys know all these, right? The pressors. So I'll just go through that. These are just the big studies from the critical care literature, right? This is the VAST trial looking at vasopressin plus Levophed versus just high-dose Levophed. No difference in mortality between the two groups, but vasopressin allows lower doses of Levophed and therefore lower incidence of arrhythmia. That's why we used it. This was another big one, dopamine versus norepi. Norepinephrine and dopamine, no difference in survival, but a trend towards improved survival with Levophed. And then if you did a subgroup analysis looking at the types of shock, the people who were in cardiogenic shock actually did have a better survival with Levophed, and that's because there were 2 times the amount of arrhythmias on dopamine. Sorry, this is supposed to be dopamine here. Dopamine than there were with Levophed. So that's why the people in cardiogenic shock did better. This is the surviving sepsis guidelines, and you guys probably know this, but now epinephrine is your second-line pressor. You guys know this, right? So all the residents will freak out when you tell them to use epi instead of neo because they love neo, but it's supposed to be epinephrine. Sean and Kevin hate neo, and so now I'm supposed to hate neo too. So epinephrine is what we're supposed to use as our second-line pressor. So we do Levophed and then vasopressin if they're in septic shock, and then if you're thinking about the third-line pressor, it's epi. They say dopamine really only with relative bradycardia, which is only the only time that I really use it if somebody's really bradycardic and hypotensive because of that. Neo, they say, is not recommended except in circumstances where it's serious arrhythmias and they mean like VT. So obviously no such thing as renal dose dopa. So the 2002 study from this guy, Anand, came out saying that everybody with septic shock needs steroids, and then he did another paper in 2008 showing that it doesn't work that well anymore. So what he did, took a ton of patients with septic shock and randomized them, right? He said, okay, you guys are going to get steroids, you guys aren't. And he stimmed everybody. And what he found was that 50% of people did not respond to the cosentropin test, which is huge, right? So that means that most people in septic shock don't respond to cosentropin. And so he said if they did have a good response to cosentropin, there's no difference in mortality if whether you're on placebo or hydrocortisone. That's pretty, right? If you have a good response, then why get steroids? However, the people who didn't respond, no difference in survival. The only thing that steroids do is it improves it kind of hastens your recovery from septic shock. So if you see here at day 5, 50% of the patients who were in placebo, the placebo group were still in septic shock versus 25% of those who were in the steroid group. So it hastens your recovery from shock, but no change in your mortality. So cosentropin test is no longer recommended. We do not do it because half the patients have a response and half the patients don't, and it doesn't change your mortality. So if you're going to use steroids, just start them. Don't do the cosentropin test. And then obviously the dose is 50 Q6. I keep on coming in the morning and patients are on like 100 Q8 or Solumedrol, like 200 Q6. I'm like, what is this? So it's 50 Q6. Make sure you tell your residents because they're just starting the craziest doses. Okay, so although we don't use CVP and pulmonary artery catheters or anything like that anymore, this is what is on the critical care boards. Tons and tons and tons of these questions where they show you SWAN numbers and they say what medicine was given to change these numbers. So that's what they ask you. So they love the SWAN still. And so you have to know your normal values and you have to know what the mechanisms of these medicines is. And so what do you think? So somebody comes in with these numbers and then they have a SWAN and then they get a medicine and it changes to this. Why do you think dobutamine?
Cardiac output went down, SVR went up, SVR went down.
Yeah, cardiac output went up, SVR went down, heart rate went up, blood pressure went up. Yeah. So you're right, it's dobutamine. So this person's in cardiogenic shock, right? And you can also look, I thought I had SVO2 in here too, didn't I? No, I guess not. And so this would be like, 55% and then goes to 72%. So this is an easy one. They'll give like, sometimes it'll be 2 different meds. They love the arterial and the venous vasodilators. So they look at those a lot. But it'll be something like this. So yeah, you're right. This is dobutamine. And then what about this one? Yeah, so this will be probably Levophed. So, and the point is that there's a little bit of an increase in cardiac output, which sometimes Levophed can have because of the beta. Whereas Neo is pure alpha, all that does is the SVR. And so that's what I was trying to get to with this, where it really has no effect on, CVP or wedge or anything like that. Just increases the cardiac output a little bit and then increases your SVR a lot because that's what Levophed does.
The same thing with dopamine would be more increasing cardiac output, just that.
And with dopamine?
Yes.
Yeah, it's a really high dose of dopamine,
right,
but like 20 mics of dopamine. Yeah, you can have a little bit of increase in your cardiac output, but Neo is not supposed to have any effect on your cardiac output because it's all alpha. So I think, and then of course this is kind of what you see as in your 4 different causes of shock. But and the key thing is that SVO2 can be high or low in your distributive shock, and then so